Hello and welcome to this podcast. This is Susan Knowles from Cochise College. During this podcast, I will be discussing abuse in pregnancy, both intimate partner violence and substance abuse from drugs and alcohol. Please also take advantage of the attached video clips where you can gain more insight into both of these issues. Thank you. According to your textbook, cigarettes are the most common substance that is abused during pregnancy, and the major consequence of smoking during pregnancy are low birth weight infants, prematurity, and an increased perinatal loss related to intrauterine growth restriction. And that's from the decreased perfusion from the active ingredients in cigarette smoke. The problem with this is it doesn't happen to everybody, so because it doesn't happen universally, it makes it really difficult to tell pregnant women that this is going to happen, and so because it's going to happen, you need to stop smoking. I tell them that when I'm counseling, but I also tell them it doesn't happen in every pregnancy. And because of that, I know that that's why some women say, well, it didn't happen in my last pregnancy, so I can continue to smoke because it's not going to happen in this one. But that doesn't always happen. For the majority of you, we've had an opportunity to actually touch, feel, and look at many placentas. And when we look at those placentas, you'll see that cigarette smoking, most likely, in many of those, has caused calcifications within the placenta, which decreases the perfusion to the baby. And we know this happens. And this is what goes on to create an intrauterine growth restriction because of the decreased perfusion. With women who are addicted to drugs or abuse drugs, oftentimes they must exchange sex for drugs because they don't have any money. This places them at increased risk of sexually transmitted infections, which we now know, again, places them at increased risk of premature rupture of the membranes and premature labor. That goes on to lead to low birth weight infants. That doesn't make pregnancy better, doesn't make delivery better. It makes babies that are at higher risk for prematurity and all of the issues that go along with prematurity. Excuse me. Cocaine is a central nervous system stimulant, as well as amphetamines and methamphetamines, and they cause similar kinds of effects of hypertension and vasoconstriction on both the mother and the fetus. Premature delivery of the infants is one of the most common problems associated with these CNS stimulants. The infant's care should be coordinated to limit the number of times the infant is disturbed, as they oftentimes have abnormal sleep patterns, they're agitated, they can be diaphoretic, and vomiting may occur during their withdrawal period. Alcohol is the most commonly used drug, and we now know, and we have for many years, that no amount or time of use is safe during pregnancy. We do know that during the first trimester, it seems to cause structural changes that are related to effects on the cells. Alcohol interferes with their perfusion and it slows down both cellular division and growth. It's thought that during the third trimester it may be the most vulnerable time because that's when the brain is growing the most rapidly, and it's the most vulnerable to alcohol exposure. We know there's a condition called FAS, and we'll talk about it more in our pediatric lecture. Fetal alcohol syndrome is the leading cause of preventable disability related to growth restriction, CNS impairment, as well as it has recognizable facial features, and the babies tend to be microcephalic. If we talk about both prescribed as well as illegal opioid drugs, and illegal drugs like heroin or methadone, these are CNS depressants, so kind of the opposite of the central nervous system stimulants like cocaine and methamphetamines. And what seems to happen with these? Well, in heroin use, the mom uses drugs intermittently, and so the baby is exposed to hypoxia intermittently, as well as maybe prescribed medications. I know that when I was in practice, many women were coming to me for migraine headaches, especially, and asking for opioid-type medications. We know that these drugs can interfere with appetite as well as with absorption of nutrients. So the patients themselves, if they're using illegal drugs, can be malnourished and anemic. They're also at risk of STDs if they're using heroin or some other medication that's used intravenously. So they're at risk for hepatitis and HIV from shared needles. Babies that are born addicted are at risk for intrauterine growth restriction as well as stillbirth. We don't really know if they'll have long-term effects such as learning disabilities. Signs and symptoms of intrauterine drug exposure can be found in your own textbook on page 818, as well as on table 24-2. And just to list a few of these neonatal abstinence syndrome signs and symptoms, babies tend to be irritable, jittery. They have this high-pitched cat cry. They have poor sleeping habits. They have a very uncoordinated sucking and swallowing, so it makes it difficult for them to feed. They have frequent vomiting. They could have nasal stuffiness and sneezing. Sometimes that might be the first thing that's seen in the nursery. They also can be tachycardic and have retractions. Moving on to intimate partner violence, it's more prevalent than we realize. All women should be asked about it and maybe asked several times. I don't know about you, but I too would be uncomfortable about asking about it at every single visit. But I do know that it has been discovered when I was in practice, and probably I wasn't very good at asking about it. Just as your textbook talks about it, we all are somewhat uncomfortable about asking about abuse. But we do need to look for the signs and symptoms of the nonverbal, not making eye contact with us, injuries or vague complaints, as well as discrepancies between injuries and the history and how it actually occurred. There seems to be a cycle of violence, and drugs and alcohol can make it worse, but they are not the cause. It's about power and control over a woman. And it happens much more often that it's a man against a woman than it is women against men. The cycles are listed as being tension building, the battering phase, and then there is the honeymoon phase. During the tension building phase, the batterer becomes increasingly hostile, swears, threatens, throws things, and pushes the woman around, the person being battered. And often the batterer increases the use of drugs and maybe alcohol during that tension building phase. During the battering phase, this is where the incident occurs. This is where violence actually occurs, and the victim often feels powerless. And then the third phase, as I said, is that honeymoon phase. And this is where the battered person wants to believe that the batterer they won't do it again. And they themselves, the one that's being the batterer, they often promise that they're not going to ever do it again. And they'll promise anything to get back into the home with her. The nurse needs to know that she needs to interview the woman alone. And when the nurse is alone with a battered client, the nurse should stress that the client is not at fault, no matter what the excuses that she gives. No one deserves to be hurt, and it's not your fault. We need to make sure that they understand that. How can I help you? And it's essential for us to accept the decisions of that battered woman, no matter what we think. We think, oh, she needs to get out of there. She needs to, not let this not allow this to continue to happen. But she's on her own times table, and we need to accept that. And we need to give her the information, and she needs to do what she can do to get out. And usually getting out is the most dangerous time. We need to be careful not to pass any judgment against her partner, because she most likely is going to go back with him. We need to help her with a plan, give her the information, as well as referral sources. Thank you for joining me on this podcast. This is Susan Knowles from Cochise College Nursing.